My name is John Fountain. I'm a registered respiratory therapist and I work at Lakes Region General Hospital in New Hampshire. I've been a respiratory therapist since 1989 when I did some on-the-job training, and I got my associate's degree in respiratory therapy in 1991, and I've been working ever since. I went to Northern Essex Community College in Haverhill, Massachusetts. At the time there were some other options. There was Northeastern University and there was another school that was closer to PB, but I chose Northern Essex because it was kind of centrally located and they had a good program at the time. The program's an associate's degree program. In the past, when I first took the training, there was a certificate program, and then you could also obtain your associate's degree. And now, as things are changing in nursing and respiratory as well, there's just going to be a registry exam starting next year, and they're going to do away with the certificate program. I've worked in all aspects of respiratory care. I've provided neonatal respiratory care, cardiac intensive care, adult critical care, pediatric critical care. I've worked in nursing homes as part of a ventilator unit for patients that require extended ventilation outside of the acute facility. And I've been on neonatal transports, adult transports, cardiac transports. I've been a member of the board of the Vermont New Hampshire Society for Respiratory Care, and I'm a member of the National Board for Respiratory Care as well as the American Association for Respiratory Care. Beginning, I was a medic in the Army Reserves, and through the Army Reserves they had offered at that time a civilian contract training program where you could go into nursing, respiratory therapy, or you could go into radiology technology. At the time there was a 2-year waiting list to get into the nursing program, so they had asked if anyone wanted to go into respiratory therapy, and I thought, why not? It's one body part, how bad could it be? Since then I learned that one body part entails a lot of training and a lot of education, similar to nursing with microbiology, anatomy and physiology, pharmacology, and all the then respiratory specific training. I was that kind of person that didn't think I'd see myself in the medical profession taking care of other people, but because the training happens so gradually, even if you don't think it's something you can do, ultimately you find yourself doing it and realize, yes, you can do it. And I think that's the same with nursing or anything that you get into. I think you have to have a fundamental compassion for people and be willing to help and willing to learn, and keep your mind open. And you talk about working together with the different disciplines. Respiratory works alongside of nursing. We work alongside of the physicians, the paramedics, the medical doctors, everybody that, pharmacists, physical therapy. We work with everybody in the hospital as you do as a nurse. So I think having good interpersonal skills and realizing that we're part of a team and not an individual, and that we share a role, and I can educate you in certain things as well as you can educate me in certain things. So I think keeping an open mind and working together is really key. So if you have those types of attributes, I think they're very good to help you get through the program. If anyone has any previous medical experience as an EMT, as a paramedic and things, that it's a good program to get into too. One of the good things that you think about sometimes is we deal a lot with from the waist up, so we don't have to deal with a lot of other things that the nurses have to deal with on a regular basis. So we're talking about collaboration between nursing and respiratory therapists, and I think that that's key. Actually, the collaboration between all members of the medical staff throughout the hospital is probably key. Some examples of good and bad would be sometimes when the respiratory therapist is called by the nurse to give a treatment. So they'll call the respiratory therapy department and they'll say, please give bed, blah, 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 treatment. And you ask the question as to why. Well, I just think he needs one. Or there's really no, there's no appreciation for a good understanding that the nurse is asking for it, or why they're asking for it. And then you go upstairs and you ask questions. Oh, when did this start? Have they been having trouble breathing? Or they may look completely fine, and you assess them, their lungs are clear, and come to find out that really can't offer any information. Maybe it was just a room where you had a gown up and glove, and you go in the room, and maybe the nurse didn't want to go in the room at that moment, so you go in to find out that the patient needed something that wasn't even respiratory related, but there was an assumption made that a treatment should be given. And sometimes the response back is, well, if you gave a nebulizer, there's no issues giving a nebulizers back to back. People don't think of it, sometimes as being a drug, but it is. And when you propose the question, well, would you give, a Tylenol to that patient? The response is typically, well, I need an order from the physician, or they just had one, a couple hours ago, and I just can't give that out. Yet sometimes we put oxygen on freely without watching the amount, and we give nebulizers, out freely. An example of great collaboration that you see all the time in the hospital is during a rapid response. So if you kind of treat each patient as almost like a rapid response where, nurse is calling respiratory, or respiratory is asking for the nurse's help to go in and make an assessment of the patient, it's helpful when the nurse is there to offer their insight as to what the patient had been doing. So, you say, well, they look like they're breathing okay. Well, a couple minutes ago, the nurse might say, they were struggling, their respiratory rate was high. I heard some wheezes, some stridor. They've had a cough for a little while, and I don't understand, and a lot of times that input, you may find, oh, there's food on their stomach, they were eating something, oh, maybe they aspirated, you listen to the breath sound. So it's important sometimes when you call somebody to assess the patient that, if you're asking someone to assess the patient, that you respect the experience of the respiratory therapist and what they're trying to convey as far as whether they thought they needed a treatment or didn't need a treatment. And the same token, it's up to us to listen to the nurse and for the nurse to be there to share their experience as to what led to this point where they required something. Sometimes post-operatively the patients, they're sedated, or the patient may be a COPD, but they're fresh post-op. So is it they're on too much oxygen, or is it because they've had too much sedative after post anesthesia? So there's all that working together helps to identify, starting with the patient, what's the best way to treat the patient, what's the best way to help the patient, what were the incidents leading up to this situation, and then what can we do to make them better. It's how we should always kind of look at, how we work with the patient from both sides. Sometimes there can be, and it's on either side of the coin, there can be respiratory therapists that are headstrong, and there can be people on the other staff in nursing that can be a little headstrong. And I think if you look at the patient as being the ultimate goal, what can we do best for the patient, I think a lot of those power struggles go away. We have an expertise in managing the airway, and what I require of my staff is to try and stay on top of new trends, new techniques, and know all the equipment that we have in the house. So it would be expected that we would be asked at times if the patient needs something to intervene and to share our knowledge on that. The ventilators, a lot of times in the ICU, nursing can be very familiar with the ventilators, but some of the nuances in the ventilator system so that you can make it more patient-friendly. The therapist has a better grasp on those things and we can work together. On the other side of the coin, sometimes you'll see respiratory therapists, as a first line, they ask for sedation because the patient doesn't seem to be ventilating well, or you're having issues with the patient. And nurses certainly know the types of sedatives and things that can be given, the duration, what works best, or what the goal is for the physician to maintain that level of sedation. And sometimes sedation isn't the answer. the therapist has to know the job and be able to manage the ventilator so the patient gets the breath when they need the breath. It's easy to trigger. The flow is available. They're satisfying the demands of an arterial blood gas and the patient's physiology to achieve the goals they want to achieve. So you have to work together so that the patient isn't under sedated, they're not over sedated. The respiratory therapist has the machine working optimally for that patient so that they're ventilating well, and that has to be done collaboratively. So I think sometimes people need to just be careful of their situation, realize that we all should be working together and we can learn from each other. I don't think there are negatives per se, because if you think as an optimist, then you can always find something that you enjoy. There are different areas in respiratory that you certainly can change your environment if you want. Like you can specialize in neonatology, you can specialize in cardiac, you can do acute care, or you can do regular hospital therapy. You can also do a lot of respiratory therapists go on to become physician's assistants. Respiratory therapists also work in polysomnography offices doing sleep studies. Certainly in healthcare, you always have the opportunity to make a difference. And I've seen patients come around from babies this big to adults, and when the patient is able to leave your facility and they're ambulating again, and they're able to be with their family for a longer period of time, whatever that time is, then you know that you made a difference in their life. We do a lot of patient instruction and to teach patients how to take their medications and how to work with their machines, their CPAP units, their ventilator units, how to suction, how to do self-care as you do in the nursing field. And it's really good when you can see those people out in the community still moving around, and they're able to function maybe a little bit better because of your input and the fact that you care. So I think that's probably the biggest thing, is just wanting to make a difference. Sometimes it's small and sometimes it's huge, but if you put your best foot forward every day in some way, you're going to make a positive change in somebody's life. And I like that feeling.